Today's topic is cardiovascular system. In cardiovascular system, we will discuss 5 main topics. These are hypertension, congestive heart failure, anginas, arrhythmias, and antidyslipidemic drugs. We'll start with, we'll discuss the topic of congestive heart failure. So as the name tells, heart failure means this is a condition characterized by inability of heart to do its function. Function of heart is to supply the blood to all parts of the body according to their requirement. So when heart is not able to do that, it is called heart failure. Now if we see, we have 4 chambers of the heart: right atrium, right ventricle, left atrium, left ventricle. Now left ventricle pumps the blood all over the body through aorta. All over the body. On the other hand, right ventricle, it pumps the blood mainly into the pulmonary circulation. It reaches the lungs. Now from the lungs, the blood will reach the left atrium. From there it will reach the left ventricle. Again it is pumped all over the body. Superior and inferior vena cava bring the blood into the right atrium. So the circulation we all know. Suppose there is left ventricular failure. That means left ventricle is not able to pump the blood. So when left ventricle is not able to pump the blood, first of all, body parts will not get the blood. Second, blood will accumulate in the left ventricle. Left ventricle get the blood from the left atrium. So it will start accumulating here. Left atrium get the blood from the lungs. So it will start accumulating here. So left ventricular failure will result in pulmonary edema. Similarly, if right ventricle fails, the blood will accumulate in the right ventricle. It leads to accumulation of blood in the right atrium. Right atrium takes the blood from inferior and superior vena cava. It will accumulate there. Inferior vena cava take the blood from the lower part of the body like liver. So blood will accumulate in the liver, leading to hepatomegaly, congestive hepatomegaly. Superior vena cava take the blood from the jugular veins. So blood will accumulate here, resulting in increase in jugular venous pressure. So basically what is happening is, when blood is not pumped, that means when the heart fails, it will lead to accumulation of blood in the areas from where it was getting the blood. In case of left ventricular failure, there is pulmonary edema, whereas in right ventricular failure, there is accumulation of blood in the liver and jugular veins. So that will lead to hepatomegaly and increase in jugular venous pressure. And we all know accumulation of fluid is known as congestion. So that's why the term used in heart failure is congestive hepatomegaly. So due to failure of heart to pump, the fluid accumulates in different parts of the body. This is called as congestive heart failure. So based on this pathogenesis, the simple aim of treatment in heart failure or congestive heart failure are 2 aims. We have 2 problems, so we have to treat those 2 problems. The first problem is the blood is getting accumulated in the different parts of the body. So we have to remove the excessive fluid. Second, heart is not able to pump, so we need to increase the pumping activity of the heart. These are the 2 main aims in the treatment of congestive heart failure. The drugs which are used to remove the fluid from the body are diuretics. And the drugs which increase the pumping activity of the heart, they are called as inotropics. Diuretics and inotropics are the 2 main drugs which are used in congestive heart failure. We will discuss these one by one. We'll start from diuretics. Now diuretics in congestive heart failure, we mainly use 2 types of diuretics. One are called loop diuretics like furosemide. Second are called thiazides. The basic difference between these 2 group of diuretics are, loop diuretics are very strong diuretics. They are called as high ceiling diuretics. High ceiling diuretics means they have high efficacy. That means they can remove large amount of fluid from the body. Large amount of sodium and water can be removed from the body. On the other hand, thiazides are relatively weak diuretics. That means they can remove little bit of sodium and water from the body, but not large amounts. But most of the loop diuretics are short acting, whereas most thiazides are long acting. So based on these two differences, we will prefer loop diuretics in case of congestive heart failure or most cases of edema, because loop diuretics can remove large amount of fluid from the body. On the other hand, thiazides are weak diuretics, so they are not very effective in conditions like congestive heart failure. But because of their long action, they are preferred in hypertension, which we'll cover later. So in congestive heart failure, we'll use loop diuretics. Now, both loop diuretics and thiazides have some common side effects, and these side effects are side effects of loop and thiazides common. They remove sodium from the body. We all know they cause loss of sodium and water. Loss of sodium can lead to hyponatremia. Now, not only sodium, they can remove most of the ions from the body. They can remove potassium, they can remove hydrogen, they can remove magnesium. So both loop and thiazides, they can result in hyponatremia, hypokalemia, metabolic alkalosis and hypomagnesemia. Similarly, both of them, they cause increase in metabolic substances, like they can cause increase in blood sugar, increase in serum lipids, increase in uric acid. So both loop diuretics and thiazides can result in hyperglycemia, hyperlipidemia and hyperuricemia. These are the common side effects of both loop diuretics and thiazides. And you need to remember only one difference between the two, and that difference is effect on calcium. One diuretic increase calcium and one diuretic decrease calcium, and this you can remember from the simple word loop loses calcium. Loop loses calcium. That means loop diuretics will cause loss of calcium. That means loop diuretic can result in hypocalcemia. On the other hand, thiazides are opposite, so they will result in hypercalcemia. That is the only important difference you need to remember. Loop diuretics cause hypocalcemia, thiazides cause hypercalcemia. So diuretics, particularly loop diuretics, they are used in congestive heart failure. So first group of drugs we have covered in congestive heart failure. These are diuretics. They will remove the fluid and give symptomatic relief to the patient. Now second problem was body is not able to pump the blood. So we need to give a drug which can make the heart pump the blood, and these drugs are called inotropic drugs. So inotropic drugs we are going to discuss now. Inotropics. Normally on the heart we have beta 1 receptors. We know beta 1 will stimulate the heart. So if a drug stimulates the beta 1 receptor, then it can be used as an inotropic drug. And we discussed in the autonomic nervous system, there are several drugs which can stimulate beta 1 and used in congestive heart failure. These drugs include dopamine, dobutamine, noradrenaline, isoprenaline. So all of them can stimulate beta 1 receptors and can be used in congestive heart failure. Now, quick recap of these drugs. Dopamine stimulates 3 receptors in the body in sequence: D1, beta 1 and alpha. Dobutamine is primarily beta 1 agonist. Noradrenaline we discussed as not all. So it stimulates the sympathetic receptors but not all. So it stimulates alpha 1, alpha 2 and beta 1 receptors but does not act on beta 2. Isoprenaline mainly act on beta 1 and beta 2 receptors. Now if we see carefully, all of these drugs, the common point is they can stimulate beta 1 receptors. And in case of inotropic effect, we want beta 1 action. So any of these can be used in congestive heart failure. If we discuss in detail how beta 1 stimulates the heart, so we'll need to discuss that if this is a cell, we know beta 1 is a G protein coupled receptor. So this is a beta 1 receptor and this is a G protein. So when we give any of the drugs which stimulate beta 1 receptors, it will bind to the receptor. Receptor will stimulate the G protein. G protein breaks into two components. One is inactive and one is active. And this active component in case of beta 1 receptors act by increasing cyclic AMP. So basically it is cyclic AMP which will stimulate the heart. That means if we increase cyclic AMP by any other method, that should also stimulate the heart. And the second method we employ is we inhibit the metabolism of cyclic AMP. So normally cyclic AMP is metabolized by an enzyme called phosphodiesterase. Phosphodiesterase metabolize cyclic AMP. So if we give a drug which inhibit this metabolism, then cyclic AMP level will increase. And when cyclic AMP level increase, it will stimulate the heart. So inotropic effect can be produced. So these type of drugs are called phosphodiesterase inhibitors, and they can also be used as inotropic drugs. And the drugs in this category are phosphodiesterase inhibitors. They are amrinone and milrinone. Amrinone and milrinone, these are phosphodiesterase inhibitors. They act by increasing cyclic AMP via inhibition of the enzyme phosphodiesterase. Now if you see, we discussed drugs stimulating beta 1 like dopamine, dobutam. They also increase cyclic AMP. And we discussed drugs inhibiting phosphodiesterase like amrinone and milrinone. They also increase cyclic AMP. So what will be the difference between these two drugs? So basic difference will be beta 1 agonist will increase cyclic AMP only at that place where beta 1 is present. And we know beta 1 is mainly present in heart. So they will increase cyclic AMP mainly in heart. So their predominant effect will be inotropic. On the other hand, phosphodiesterase inhibitors, they will increase cyclic AMP in all the places where phosphodiesterase is present. And phosphodiesterase is present in both heart as well as blood vessels. That means phosphodiesterase inhibitors, they will increase cyclic AMP in heart as well as blood vessels. When they increase cyclic AMP in the heart, they will produce inotropic effect. But when cyclic AMP increase in the blood vessels, it results in vasodilation. So phosphodiesterase inhibitors have one extra effect apart from beta 1 agonist, and that extra effect is vasodilation. So if we see the effect of phosphodiesterase inhibitors, so this include inotropic effect as well as vasodilator effect. So we combine these together. So phosphodiesterase inhibitors, they are known as inodilators. Inodilators. Phosphodiesterase inhibitor group of drugs are called inodilators. They will produce inotropic as well as vasodilatory effect.
In case of right-sided heart failure, the predominant action required is vasodilation. So if they ask which is the inotropic drug of choice for right-sided heart failure, so it will be phosphodiesterase inhibitors or simply inodilators. Okay.
So these are the second drugs which can be used in congestive heart failure, which increase the contractility, that means inotropic effect. Now, third group of drugs used in congestive heart failure. Now first we'll discuss the disadvantage of the first two drugs. We discussed beta 1 agonist can produce inotropic effect. We discussed phosphodiesterase inhibitors can produce inotropic effect. But the problem is, both of these groups, they act by increasing cyclic AMP, and cyclic AMP cannot differentiate between different activities of the heart. Means heart has three main activities. One is heart rate, second is conduction from atrium to ventricle, and third is contractility. So in congestive heart failure, we will like to increase the contractility because heart is not pumping, so we will like to increase the contractility. But these drugs, both of these groups, they increase all the three things. That means not only they increase contractility, which is required, but they also increase heart rate and conduction, which is not required. So we will want such a drug which increase only contractility, which do not increase heart rate or conduction. What is the disadvantage of increasing heart rate? So it is obvious that if heart will contract more number of times, it will have to do more work. And we already discussed heart is failing, heart is not doing its normal work, and this extra work will be detrimental for heart. So we will want a drug which do not increase heart rate, which increase contractility. So in search of such a drug, we found the next group of drug which is called as digoxin. Group of the drug is called as digitalis. The other name of this group is cardiac glycosides. Cardiac glycosides. Digoxin or cardiac glycosides. Now first of all, how digoxin works. Before going to mechanism of digoxin, we'll discuss first how normally the ventricular fibers contract. If you see, this is the cell. This is a ventricular muscle cell. Like every cell in the body, it also has same pump, which is called sodium potassium pump. And we all know the function of this pump is sodium goes out, in exchange potassium comes in. Now in the cardiac muscle, there is one more pump present, which is called as NCX. NCX means sodium calcium exchanger. So as the name tells, sodium and calcium will be exchanged. That means if one comes in, second will go out. They will be exchanged. Now you can remember the direction of this pump from the direction of sodium potassium pump. Now we know that from sodium potassium pump, sodium is going out. So when sodium is going out means it will be less inside. So when sodium is less inside, sodium will enter from here. Now as the calcium has to exchange, so it will go out. So through the NCX, sodium enters and calcium goes out of the cell. Now how the normal muscle contracts? We know when normal muscle has to contract, we want depolarization. So depolarization occur, that lead to opening of the L-type calcium channels in the cells. Calcium channel opens, and this will lead to entry of calcium. So calcium will enter inside the cell. We know for muscle contraction we require calcium. So calcium has entered, so it should cause muscle contraction. But this does not happen. The reason is amount of calcium entering the cell is very small. For muscle contraction we require large amount of calcium, but this is very small. So example sake we consider, suppose only 10 molecules of calcium enters. But for muscle contraction we want around 1000 molecules of calcium. So these 10 molecules will not be able to produce muscle contraction. So what we do, we know that there is a storehouse of calcium in the cells, and that is called endoplasmic reticulum. So this is the endoplasmic reticulum of the cardiac muscle. Endoplasmic reticulum of the muscle cells is called as sarcoplasmic reticulum. Sarcoplasmic reticulum is already storing the 1000 molecules of calcium which we want for muscle contraction. But we want this calcium in the cytoplasm to cause muscle contraction. So these 10 molecules of calcium, what they will do is they will request the endoplasmic reticulum to release calcium. And how they request is they will stimulate a receptor present on the endoplasmic reticulum, and this name of this receptor is ryanodin receptor. So they stimulate a receptor called as ryanodin receptor. When ryanodin receptor is stimulated, the calcium which is stored in the endoplasmic reticulum, it will be liberated out. So 1000 molecules of calcium, they come outside. So when this 1000 calcium comes out, now it can cause interaction of actin with myosin, and that lead to muscle contraction. So calcium enters from outside, small amount. It stimulates the ryanodin receptor on the sarcoplasmic reticulum. That lead to release of calcium from the sarcoplasmic reticulum. So now this will cause muscle contraction. Now after some time, the muscle has to relax. So when the muscle relax, this calcium will become free again. So now what we do, we will return this calcium back to endoplasmic reticulum, and how it is returned is there is presence of another pump here, and the name of this pump is SERCA. This pump is named as SERCA. SERCA is sarcoplasmic endoplasmic reticulum calcium ATPase. So in simple language it is calcium ATPase. The abbreviation is SERCA. So this calcium ATPase, it will take back its 1000 molecules of calcium. So sarcoplasmic reticulum has provided 1000 molecules of calcium to cause muscle contraction, and the same 1000 comes back in the sarcoplasmic reticulum through SERCA. Now what about these 10 molecules of calcium which have entered from outside? So these 10 molecules of calcium which has entered during the depolarization, they will go out through the sodium calcium exchange. So basically the calcium which has entered from outside will go out, and the calcium which has come from the endoplasmic reticulum will go back into the endoplasmic reticulum. So that means the cell will again become as earlier normal cell. So the same thing will repeat in the next depolarization. That means again depolarization occur, small amount of calcium enters, it will stimulate the ryanodine receptor on the endoplasmic reticulum, more calcium will be liberated from the endoplasmic reticulum, it will cause muscle contraction, and when the muscle relax, endoplasmic reticulum calcium will be returned, and the calcium entering from outside will go outside. Is it clear? So this is the normal muscle contraction. Now how digitalis work? How digitalis work is, digitalis act by inhibiting this sodium potassium pump. Digitalis inhibits sodium potassium pump. So when we give digitalis, this pump is not working. So when this pump do not work, means sodium cannot go out. And when sodium is not able to go out, it will accumulate inside. So when sodium is more inside the cytoplasm, more sodium is not required. So entry of sodium from the NCX stops. So indirectly sodium calcium exchanges stop working. So that means when this sodium is not coming, so in exchange calcium is not going out. So when calcium is not able to go out, what will happen to this 10 molecules of calcium? Instead of going out, because it cannot go out, so this will also start going inside the endoplasmic reticulum. So digoxin inhibits sodium potassium pump, that lead to increase in intracellular sodium. As sodium is more inside, so NCX stop working. So when NCX is not working, calcium cannot go out. So that calcium which has to go out now will start going inside the endoplasmic reticulum. But will you expect that just 10 extra molecule in the endoplasmic reticulum will increase the contractility significantly? Obviously no. But what is happening is, instead of 1000 molecules of calcium, now we have 1010 molecules of calcium inside the endoplasmic reticulum. So when the next depolarization occur, 10 molecules of calcium come, they will stimulate the ryanodine receptor, and now the endoplasmic reticulum, it will release 1010 calcium. Is it clear? But 1010 calcium will not significantly increase contraction. But in this bit also same thing happen. So those 10 molecules which have entered from outside cannot go out because NCX is not working. So this will again enter the endoplasmic reticulum. So now the endoplasmic reticulum contains 1020 calcium. In next beat it will contain 1030 calcium, and after several beats it will contain 2000 calcium. And when 2000 calcium are released, it will lead to significant increase in contractility. So digitalis cannot produce immediate effect. It will gradually increase the calcium in the endoplasmic reticulum, and after some time there will be significant increase in contractility. Okay? So now just revising the mechanism of action of digitalis. Digitalis inhibit sodium potassium pump. Inhibition of this pump will indirectly result in inhibition of sodium calcium exchange. So when calcium is not able to go out, there will be increase in calcium in the plasma. Sorry, not plasma, increase in calcium in the cytoplasm. When calcium increase in the cytoplasm, finally it will go more inside the endoplasmic reticulum. More calcium in the endoplasmic reticulum, and more calcium in the endoplasmic reticulum will lead to increase in contractility, because that calcium will be released and cause contraction. So this is the mechanism of action of digitalis in congestive heart failure. Now, as compared to other inotropic drugs, digitalis do not increase the heart rate, so it will not increase the work of heart. But rather than this, digitalis has one more mechanism. Digitalis has vagomimetic effect. Vagomimetic effect. Vagomimetic means it will have parasympathetic effect. Remember, vagus is a parasympathetic nerve to 10th cranial nerve, and we know parasympathetic system depress the heart. So due to its vagomimetic action, rather than increasing, it actually decrease heart rate and decrease conduction from atrium to ventricle. Digitalis decrease heart rate and decrease conduction. But do you want to decrease rate and conduction in CH? Obviously no. So as such, this is not of any use in case of congestive heart failure. But unlike other drug, this is not of disadvantage because it do not increase the work of heart. But this action of decrease in rate and conduction we utilize in another disease which is called as atrial fibrillation. Atrial fibrillation. Atrial fibrillation is a condition in which atrial rate is very high. When we say heart rate of a person is 80 beats per minute, so what do we mean? What is contracting 80 times in 1 minute? Is it atrium or is it a ventricle? Yes, it is both. So 80 beats a minute means SA node gives 80 impulses every minute, and all these 80 are passed to atrium. Atrium contracts 80 times in 1 minute, and all these 80 are passed to ventricle. Now ventricle contract 80 times every minute. So that means every part of the heart is contracting same times per minute. Now when we say atrium or ventricle to contract 80 times in 1 minute, so they have enough time. That means they have to contract 80 times in 60 seconds. So they can completely contract and relax. Contract and relax. That means they can effectively pump the blood. They can do that 80 times in 60 seconds. Now in atrial fibrillation, the heart rate is very high. The atrial rate in this condition is around 400 to 500 beats per minute. That means atrium or ventricle have to contract 400 times every minute. So when atrium has to contract 400 times in 1 minute, 500 times in 1 minute, so how it will do? So it will start contracting, relaxing, but then it realizes that it cannot do like this for 500 times in 60 seconds. So what it does, instead of complete contraction and relaxation, it just start fibrillating. Slight contraction, relaxation, contraction, relaxation, contraction, relaxation. That means it cannot completely contract. It just complete its number. So it does it 500 times in 1 minute, but the contractions are ineffective. So those ineffective contractions are called fibrillations. So in atrial fibrillation, the rate is very high, but all the contractions are ineffective. The question is, if atrium do not contract completely, that means if atrium do not pump the blood, will it be of severe significance, severe consequences? The answer is no. Reason? Atrium has to give the blood just to ventricle. So even if it do not contract completely, even then the blood can go by gravity also. So in atrial fibrillation, there is not significant hemodynamic compromise. But problem is, normally we discuss that all 80 contractions will pass to ventricle. If all 500 are passed to ventricle, then ventricular contractions will also become ineffective. That means ventricular fibrillation can occur. And if ventricle do not pump the blood, it will lead to heart failure and all the problems. So in atrial fibrillation, our major aim is we do not want ventricular fibrillation. So most of the drugs which are used in atrial fibrillation, they are targeted to prevent the increase in ventricular rate. So same is done by digitalis also. So digitalis, what it do is it decrease the conduction from atrium to ventricle. Digitalis decrease the conduction from atrium to ventricle. That means out of 4 or 5 atrial beats, only 1 will go to ventricle. So if 1 beat out of 4 go to ventricle, so even if atrium is contracting at 400 times, only 100 will be passed to ventricle. So that means ventricle will beat at 100 times per minute. So when it beats 100 times in 1 minute, it can pump the blood. So the major problem will not occur. So digitalis can be used in atrial fibrillation, but the major mechanism is decrease in conduction from atrium to ventricle. So digitalis has 2 main uses. First is congestive heart failure, where major mechanism is inhibition of sodium potassium pump. Whereas it has second mechanism in atrial fibrillation, where it decreases the conduction from atrium to ventricle. Now coming to drugs. Digitalis is name of the group of drugs. The only drug which is available now is digoxin. Digoxin is name of the drug. Whereas few years earlier, one more drug is present in the digitalis group, which is digitoxin. Now digitoxin has been withdrawn, only digoxin is available. But commonly the question is asked between the difference between these two drugs. What is the difference between digoxin and digitoxin? And you can easily remember, one of them is metabolized by liver, one of them is mainly excreted by kidney. And that you can remember is digitoxin, the name start with toxin. So when the name contains toxin, and we know all the toxins are metabolized in liver, so this will also be metabolized in liver. So digitoxin is mainly metabolized by liver, whereas digoxin is mainly excreted by kidney. So due to this reason, digitoxin was contraindicated in renal failure, liver failure. Digitoxin was contraindicated in liver failure, whereas digoxin is contraindicated in kidney failure. Remember, now only digoxin is available, digitoxin has been withdrawn now, and digoxin is contraindicated in renal failure. Another important thing to remember, digitalis group, or in fact digoxin, is the only drug which is used in congestive heart failure, act as inotropic drug and can be given orally. Remember, among all the inotropic drugs, only drug that can be given orally is digoxin. Adverse effects of digoxin. What are the most common adverse effects? Like every drug, most common adverse effects of digitalis group of drugs is also nausea and vomiting. So GIT side effects are most common side effects of digoxin. Now, apart from GIT, digoxin can cause arrhythmias. If you discuss the mechanism of action of digoxin, we discussed two mechanisms. One, it increases calcium. So when calcium increases, it will try to stimulate the heart. But at the same time, digoxin also decreases the conduction from atrium to ventricle. That means it has vagomimetic effect. And due to vagomimetic effect, heart gets the information that I have to get depressed. So vagomimetic effect will inhibit the heart. So digoxin is doing two things. One, it is stimulating the heart by increasing calcium. Second, it is inhibiting the heart by vagomimetic effect. So when we give digoxin, the heart gets confused what to do. So in this confusion, heart will start doing its own work. So that means it can undergo arrhythmias. So any type of arrhythmia can occur, tachyarrhythmias as well as bradyarrhythmias, depending upon which is more. Okay. The question asked on digitalis induced arrhythmias are, what is the most common arrhythmia caused by digitalis? The answer to this is ventricular bigeminy. Ventricular bigeminy is the most common arrhythmia caused by digitalis. But read the MCQ very carefully, because sometimes the question is asked, what is the most common adverse effect of digitalis? And they give first option as ventricular bigeminy, which is not the answer. Remember, overall, most common side effects are GIT side effects like nausea and vomiting. But among the arrhythmias, most common is ventricular bigeminy. Second question asked is, what is the most specific arrhythmia caused by digitalis? Most specific arrhythmia, or also called as most characteristic arrhythmia caused by digitalis. First of all, what is the difference between these two questions? Most common arrhythmia means whenever digitalis overdose occur, it is likely to occur. But this is not caused only by digitalis. Ventricular bigeminy can be caused by 10 other drugs also. So when ventricular bigeminy is present, we are not 100% sure that it is caused by digitalis, but it is commonly seen in digitalis overdose. But on the other hand, when we say most specific or most characteristic, it means that although it is not common, but if this arrhythmia is present, we are almost 100% sure that it is caused by digitalis. So that means it is characteristic of digitalis. Other drugs are not able to cause this arrhythmia. And the most specific arrhythmia caused by digitalis is non-paroxysmal atrial tachycardia. Non-paroxysmal atrial tachycardia with atrioventricular block. Non-paroxysmal atrial tachycardia with atrioventricular block is the most characteristic arrhythmia caused by digitalis. Remember, most common arrhythmia is ventricular bigeminy, but most specific arrhythmia is non-paroxysmal atrial tachycardia with AV. Then third important question asked is, which arrhythmias are not seen in digitalis toxicity? Now, this is just theoretical, that till now these arrhythmias have not been found in overdose of digitalis. And these arrhythmias are, one is atrial flutter, and second is Mobitz type 2 heart block. Mobitz type 2 heart block. So these two arrhythmias are not seen in digitalis poisoning. So three important questions: one, most common arrhythmia; second, most specific arrhythmia; and third, which arrhythmias are not seen in digitalis poisoning. So most common adverse effect of digitalis are GIT side effects. Then it can cause arrhythmias. Apart from these, digitalis can cause gynecomastia. Gynecomastia is development of male breasts. So digitalis long-term use can result in gynecomastia, development of male breasts. And another important thing to remember, which other drugs are commonly associated with gynecomastia. And these drugs you can remember as disco drugs. Drugs causing gynecomastia you can remember as disco drugs. Disco drugs you can remember DI for digoxin. We just discussed digoxin can cause gynecomastia. S for spironolactone. Spironolactone is a potassium sparing diuretic. It can also result in gynecomastia. C for cimetidine. Cimetidine is a drug used in peptic ulcer. It can also cause gynecomastia. O are estrogens, and obviously we know estrogens are female hormones, so it can cause female symptoms, gynecomastia. So disco drugs, they can result in gynecomastia. So digitalis, third side effect is gynecomastia. Lastly, digitalis can cause color vision defect, which is called xanthopsia. The other term for xanthopsia is yellow vision. So digitalis can result in color vision defects called as yellow vision defect, xanthopsia. So these are the main adverse effects of digoxin. Now one question which is very commonly asked and very important from MCQ point of view is interactions of digitalis. And more important than interactions, we can say which factors increase the risk of digitalis toxicity. Which factors can precipitate digoxin toxicity? To remember these, we'll divide into three categories. First, metabolic factors. Second, drugs. Some drugs can increase the risk of digitalis toxicity. And third, pathological factor or disease factors. So among the metabolic factors, you need to remember three important. These are hypercalcemia, hypokalemia, and hypomagnesemia.
You can remember digoxin increases calcium. We know mechanism of digoxin is to increase calcium. So if calcium is already more, digoxin will work more, that can lead to toxicity. Similarly, if potassium or magnesium are less, remember potassium and magnesium are inhibitory, whereas calcium is stimulatory. So if potassium and magnesium are lesser, then heart will be stimulated more. So that can cause digoxin toxicity. So this is just a way to remember. It is not the reason. Actually, what happens is the sodium potassium pump which is present, which transports sodium outside and potassium inside, this pump, where the potassium binds to this pump, at same place digoxin binds. So digoxin and potassium has same place where they bind. So if potassium is more extracellularly, then digoxin has a more competition. So that means if potassium is more, binding of digoxin will be less. So digoxin binding is inhibited by extracellular potassium. So that's why if there is less potassium in the blood, hypokalemia, there will be no competition, more digoxin can bind, and that can lead to toxicity. This is one thing. But you need to be very careful. If toxicity occurs, in case of severe toxicity, when digoxin has already blocked this pump, what happens is potassium will not able to enter. When potassium is not able to enter, it will stay in the blood, so that lead to hyperkalemia. So read very carefully, these are two opposite things. Hypokalemia will precipitate digoxin toxicity, but in toxicity there will be presence of hyperkalemia. Okay.
Hypercalcemia, hypokalemia, and hypomagnesemia, they increase the risk of digitalis poisoning. Hypercalcemia, hypokalemia, hypomagnesemia. Then which drugs increase the risk of digitalis toxicity? These include quinidine, verapamil, amiodarone, and thiazides. When these drugs are co-administered with the digoxin, there is increased risk of toxicity. Quinidine, verapamil, amiodarone, and thiazides.
Thiazides, they cause hypokalemia, hypomagnesemia, and hypercalcemia. And we know all these factors, they can precipitate digoxin toxicity. So thiazide precipitate digoxin toxicity by pharmacodynamic interaction. This is pharmacodynamic interaction because thiazides do not change the plasma level of digoxin. So plasma level is same, but same amount of digoxin become more toxic. So that is called pharmacodynamic interaction. On the other hand, verapamil and amiodarone, they increase the plasma concentration of digoxin, and when plasma concentration is more, obviously the toxicity will occur. So this type of interaction is called as pharmacokinetic interaction. So thiazides have pharmacodynamic interaction to cause toxicity, whereas amiodarone and verapamil, they have pharmacokinetic interaction to cause digoxin toxicity.
Now, pathological factors we already discussed. There is increased risk of digitalis toxicity. If there is renal failure, there is a risk of digoxin toxicity. And in case of liver failure, there is a risk of digitoxin toxicity. Now, question is how to remember these. These are very important. So, to remember this is just for remember, not the reason. So you can remember digitalis mechanism is to increase calcium. So if calcium is already more, it will work more. So that will lead to toxicity. So hypercalcemia we can explain. Then we know that potassium and magnesium are inhibitory ions, whereas calcium and sodium are stimulatory ions. So if we inhibit the inhibitory ions, that means if inhibitory ions are less, it will lead to more stimulation. So that will lead to toxicity. So you can remember hypokalemia, hypomagnesemia, and hypercalcemia increase the risk of digitalis toxicity. Now the drugs you can remember if you just study it in Hindi. So in Hindi you can remember that if we give digoxin, तो जो queen है, queen की वाट लग जाएगी. So digoxin queen की वाट लगा देगी. So quinidine, verapamil, amiodarone, and thiazides. Now, pathological factor we already discussed. If there is toxin in the name, toxins are metabolized by liver. So there will be toxicity in case of liver failure. So other drug, that means digoxin, will become toxic in renal failure. So these are the important points regarding the digitalis toxicity. Lastly, how to manage digitalis poisoning or digitalis toxicity. So first and most important thing is to correct these interactions. We have discussed so many interactions. So all these, if we correct them, like if the person is taking some drug like amiodarone or thiazide, we will stop that. If there is metabolic abnormality like hypokalemia, we will correct that. So most of the time we can treat digitalis poisoning. But if still arrhythmias are present, even after correcting these, then we need to give antiarrhythmic drug. And the drug of choice for digitalis induced arrhythmias is lignocaine. Lignocaine is drug of choice for digitalis induced arrhythmias. The alternative to lignocaine is phenytoin. Phenytoin or lignocaine, they are drug of choice for digitalis induced arrhythmias. They are mainly used for ventricular arrhythmias. But as we already discussed, the most common arrhythmias in digitalis poisoning are ventricular. So mostly lignocaine like drugs can be used. But depending upon the arrhythmia, we can choose the antiarrhythmic drug. Now, if the arrhythmias are not controlled even with antiarrhythmic drugs, then we will need to give one more drug which is called as digibind. Digibind, it is indicated in severe digitalis poisoning, severe digoxin poisoning. Digibind. So as the name tells, it will bind digitalis and remove it. So digibind is a monoclonal antibody against digitalis. Digibind is an antibody against digitalis. It will bind digitalis and remove it. Indicated in severe digoxin poisoning. So these are the important inotropic drugs. So in case of congestive heart failure, we use two types of drugs. One are called inotropic drugs, which we just finished, and other drugs were diuretics, which are for symptomatic improvement. So the type of heart failure we have discussed so far, it is called acute congestive heart failure. So that means the patient will present acutely in emergency with symptoms. So we need to give two type of drugs. One, in the drug increasing contractility, and second, the drug which remove the fluid from the body. Now suppose a person develop congestive heart failure, but this person, that means this person is having low cardiac output is less, but this person do not go to any doctor. That means the person do not take treatment. So if the person do not take treatment for heart failure, what will happen? Contrary to our expectations that this person will die, this does not happen. The reason is our body has compensatory ability for everything. If anything goes wrong in the body, body will automatically correct that. But we know that we have only two arms for compensation. One is sympathetic system, second is parasympathetic system. So if a person's cardiac output is low, which arm will be activated for compensation? Yes, it will be sympathetic system. So when cardiac output is low, there will be stimulation of sympathetic system. When sympathetic system is activated, means catecholamines like adrenaline, noradrenaline will be released. And when they are released, they will stimulate beta-1 receptors in the heart. And when beta-1 receptor is stimulated in the heart, they will increase cardiac output. We know beta-1 stimulates the heart. So cardiac output is increased. Now the question is, when the body can automatically manage, it automatically increase cardiac output, then why to give the drugs? We have discussed so many drugs with so many side effects. When the body can automatically manage, then what is the requirement of drugs? The reason is, when sympathetic system is activated, will it stimulate only beta receptors? Obviously no. So it will stimulate alpha receptors also. And we know stimulation of alpha receptors will cause vasoconstriction. Constriction of veins as well as constriction of arteries. When the veins contract, it will increase work of heart, which is called preload. When the arteries contract, it will increase the work of heart, which is called afterload. So vasoconstriction will increase work of the heart, called as preload and afterload. Now before going into further details, we'll quickly discuss what is the meaning of preload and afterload. We know that left ventricle pump the blood into the aorta. Left ventricle pump the blood in the aorta. Now suppose this aorta is contracted. So when the aorta is contracted, then left ventricle has to pump more forcefully, only then the blood can go up. That means left ventricle has to do more work. After the blood has come to left ventricle, it has to work more to remove the blood if there is contraction of the arteries. So that means if the arteries are contracted, the work increases. And this work is called as afterload. So the name tells afterload means after the blood has come to heart, how much work is done to remove that blood. So afterload depends upon arteries. So if there is contraction of arteries, afterload increases. Similarly, if more blood comes to heart through inferior and superior vena cava, if more blood comes into heart, it has to pump more blood. So that work increases. And this work is called as preload. Preload. And we know when the veins contract, the blood will come toward heart. Remember, veins have one way walls only. So when the veins contract, more blood will come to heart. When more blood come to heart, heart has to pump more blood. So work increases. So that work is preload. So that means contraction of veins will increase preload and contraction of arteries will increase afterload. So we discussed when sympathetic system is activated, it will cause vasoconstriction, that will cause increase in preload and increase in afterload. Work of heart increases. Heart is not able to do normal work and we have given heart extra files to do the work, so that is detrimental for heart. So first problem with increase in sympathetic activity is work of heart increases. Second problem, when sympathetic system stimulate the beta receptors, beta 1 receptor is not only present in heart, but it is also present in JG cells of kidney. So beta 1 receptor will also be stimulated in the juxtaglomerular cells of kidney. And when beta 1 is stimulated here, what will happen? Yes, there will be secretion of renin. So beta 1 will help in release of renin. And we know function of renin. It convert angiotensinogen to angiotensin first. Angiotensin first is converted to angiotensin second with the help of enzyme. Angiotensin converting enzyme. Angiotensin converting enzyme. Angiotensin second will work on its receptors. Mainly they are AT1 receptors. Angiotensin second stimulate AT1 receptors. And when AT1 receptors are stimulated, it produces three effects. AT1 receptors are present at three places mainly. One, AT1 receptors which are present in the blood vessels, they result in vasoconstriction. Stimulation of AT1 receptors cause vasoconstriction. So this vasoconstriction will further increase preload and afterload as discussed earlier. So work of heart increases further. Second, AT1 receptors are also present in adrenal medulla and stimulation there, it results in release of catecholamines. That means adrenaline, noradrenaline, etc. will be released from the adrenal medulla. So that means they will further cause vasoconstriction. So that will further increase the work of heart. And third and most important thing is AT1 receptors are present in the adrenal cortex where they secrete aldosterone. So AT1 receptor will result in release of aldosterone. And we know function of aldosterone is to increase sodium and water retention. So aldosterone causes retention of sodium and water. Simultaneously, aldosterone also causes removal of potassium and hydrogen. So when sympathetic system remains active for long periods, there is increase in aldosterone and that causes sodium and water retention. And when sodium and water is retained, that will lead to edema again. So another problem apart from increase in work, there is edema. Now these are just two problems, but most dangerous is still left. And that is, if aldosterone remain elevated for prolonged periods, it result in left ventricular hypertrophy. Left ventricular hypertrophy. So when aldosterone increase for prolonged periods, it result in left ventricular hypertrophy, which is also called cardiac remodeling. And it is this left ventricular hypertrophy which will result in death of the person. Person do not die from acute CHF. Person develop compensatory mechanisms and finally the death occur mainly because of left ventricular hypertrophy or cardiac remodeling. So this type of situation in which cardiac output is almost normal but the patient is having totally different type of problem, this type of heart failure is called as chronic CHF. Chronic CHF, the other name of chronic CHF is compensated CHF. Compensated CHF, as the name tells, it is due to compensatory mechanisms. So aim of treatment in acute CHF and chronic CHF are totally different. In acute CHF, the major aim was to increase the contractility, whereas in chronic CHF, the cardiac output is already normal. So the inotropic drugs do not have major role in chronic CHF. So what are the aim of treatment in chronic CHF? So three main aims of treatment in chronic CHF are: first is to reduce the work of heart. We discussed the work has increased. Preload, afterload has increased. So we want to decrease that work. Second aim is to remove the fluid. Because of sodium and water retention, the fluid has accumulated. So we want to remove that fluid. And third and most important aim is to reverse the left ventricular hypertrophy, which result in death of the person. So we want to reverse the left ventricular hypertrophy. So remember, the main aim of acute CHF was to increase contractility. This is not the aim in chronic CHF because contractility is already normal. So we'll discuss one by one how we can achieve these aims. The first aim is to reduce the work of heart. And we know work was increased because of vasoconstriction. So we can reduce the work by causing vasodilation. So vasodilators are used to reduce the work of heart. And we have three types of vasodilators. One which dilate mainly veins, second which dilate mainly arteries, and third which can dilate both veins and arteries. If a drug mainly dilate veins, it will decrease preload. If a drug mainly dilate arteries, it will decrease afterload. If a drug dilate both, it will decrease both preload and afterload. The main venodilator we have is nitrate group of drugs. So nitrates are predominant venodilators. So their major aim is to decrease preload. Main arterial dilator is hydralazine. So hydralazine mainly decrease afterload. On the other hand, drugs dilating both veins and arteries, they include sodium nitroprusside, AC inhibitors, and angiotensin receptor blockers. So sodium nitroprusside, AC inhibitors, and angiotensin receptor blockers, they dilate both veins and arteries, so they can reduce both preload and afterload. So first aim was to reduce work, which we can do by giving vasodilators. Now the second aim is to remove fluid. And fluid we already know they can be removed by diuretics. And we discussed two types of diuretics, loop and thiazides. So in case of congestive heart failure, we will prefer loop diuretics because we have to remove large amount of fluid from the body. So loop diuretics, which we have already covered. Now third and most important aim is to reverse the left ventricular hypertrophy. And we discussed left ventricular hypertrophy occurs because of aldosterone. So if we see the pathway, left ventricular hypertrophy pathway starts from here. So beta 1, which is present in the GG cells, secrete renin, that will activate angiotensinogen to angiotensin 1-2, that will stimulate AT1, that will release aldosterone, that will cause left ventricular hypertrophy, which result in death. So this is the problem. So if we stop this pathway, we can prevent the death of the person. We can decrease the mortality. So what are the drugs that can decrease mortality? So right in the beginning, we can give beta blockers. So when we block beta 1, renin will not be released. So this pathway will not start. So beta 1 blockers can be used for decreasing left ventricular hypertrophy. Second, we can inhibit ACE. So angiotensin converting enzyme inhibitors. Third, we can use AT1 receptor blockers, angiotensin receptor blockers. And lastly, we can use aldosterone antagonists. So 4 type of drugs: beta blockers, AC inhibitors, angiotensin receptor blockers, and aldosterone antagonists. These are used to reverse left ventricular hypertrophy, so they can decrease mortality. So it's very important to remember, all the drugs used in congestive heart failure cannot decrease mortality. Mortality is decreased mainly by those drugs which decrease left ventricular hypertrophy, and these are the 4 drugs include the drugs decreasing left ventricular hypertrophy. They are beta blockers, AC inhibitors, angiotensin receptor blockers, and aldosterone antagonists. So 4 type of drugs, they can decrease left ventricular hypertrophy. beta blockers, their name end with LOL. So the main beta blockers which are used in congestive heart failure, the most commonly used one is carvedilol, and two more are indicated in congestive heart failure. These include metoprolol and bisoprolol. So only 3 beta blockers are approved in congestive heart failure. These are carvedilol, metoprolol and bisoprolol, and these can decrease mortality. But very important to remember, beta blockers are contraindicated in acute CHF. Remember, in acute CHF we want to increase contractility, and beta blocker can decrease contractility. So they are contraindicated in acute CHF, but they can be used in chronic CHF because they decrease left ventricular hypertrophy.
However, the dose of beta blocker should be gradually increased in congestive heart failure. If we start the full dose on the first day, it will block the beta receptor in the heart also, and that can lead to decompensation. So a person which is well stabilized will suddenly go into decompensation, or we can say acute heart failure. So whenever beta blockers are started, they are started at very low dose, around 1/10 of the final dose, and this dose is gradually increased every 2 weeks to reach the final dose in around 2 to 3 months. If we give in this manner, then they will prevent the mortality by preventing the left ventricular hypertrophy, and at the same time they will not cause decompensation also. So beta blocker should always be started in low dose, and gradually the dose should be increased.
The aldosterone antagonist which is useful is spironolactone. One new drug in this category has been formed, which is called eplerenone. So spironolactone and eplerenone, these are the two aldosterone receptor antagonists. So if we block the aldosterone receptors, so the function of aldosterone will be reversed. Whatever aldosterone is doing, that will not happen. So function of aldosterone, one was to cause left ventricular hypertrophy. So these drugs will reverse left ventricular hypertrophy. Second important thing, aldosterone cause retention of sodium and water and removal of potassium and hydrogen. So aldosterone antagonist will stop this function. So that means sodium and water cannot be retained. So that result in diuretic effect. Whereas potassium cannot be removed, so potassium will be retained. So these drugs are called as potassium sparing diuretics. So aldosterone antagonists are potassium sparing diuretics. And we already discussed spironolactone is one of the disco drugs. Disco drugs means this can cause gynecomastia. Spironolactone can cause gynecomastia, but this side effect is absent in eplerenone. Eplerenone do not cause gynecomastia. So now we are left with AC inhibitors and angiotensin receptor blockers. Now if you see, if we give AC inhibitors, angiotensin converting enzyme inhibitors, so that means this ACE is not working. So when ACE does not work, means angiotensin first cannot be converted to angiotensin second. That means angiotensin second is not produced. When angiotensin second is not produced, it cannot stimulate the AT1 receptors. So when AT1 receptors are not stimulated, we get mainly 3 effects. First, vasoconstriction will not occur. Second, catecholamines will not be released. And third, aldosterone will not be released. Okay? So vasoconstriction, catecholamines and aldosterone. So all these 3 will stop. On the other hand, if we give angiotensin receptor blockers, that means if we antagonize AT1 receptor, angiotensin second continue to be produced. That means angiotensin second production continues. But in spite of its production, it cannot work because the receptors are blocked. So the final effect will be same. That means there will be no vasoconstriction, no catecholamines and no aldosterone. So final effect of AC inhibitors and angiotensin receptor blockers are same. So due to this reason, AC inhibitors and ARBs, they have same uses, they have same side effects and they have same contraindication. So clinically they are similar drugs. The only important difference between AC inhibitors and ARBs are that ACE has one more function, and that function is to break bradykinin. ACE also cause metabolism of bradykinin. Bradykinin metabolism is also done by ACE. So that means when we give ACE inhibitor, they inhibit the conversion of angiotensin first to second, which result in same effect as produced by angiotensin receptor blockers. But in addition, it will inhibit the conversion or metabolism of bradykinin. So when this pathway is stopped, the level of bradykinin increases. So ACE inhibitors will increase the level of bradykinin. And when bradykinin increases significantly, it can result in two side effects. Increase in bradykinin, it results in two important side effects. One is dry cough and second is angioedema. Increase in bradykinin can result in dry cough and angioedema. These two side effects are present in ACE inhibitors, but they are not present in angiotensin receptor blockers. So that is the major clinical difference between ACE inhibitors and angiotensin receptor blockers. So now we can discuss more important points about the ACE inhibitors first. The name of ACE inhibitors, it end with pril. ACE inhibitors, the name end with pril. Any drug ending with pril is ACE inhibitor. The examples are captopril, lisinopril, enalapril, ramipril, perindopril, moxapril, and many more prils are present. So any drug which end with pril is an ACE inhibitor. Drugs ending with pril are ACE inhibitors. And all the important points regarding the ACE inhibitors we can remember from the first drug captopril. So captopril is used to remember all the important points regarding ACE inhibitors. So we'll write captopril. Captopril. C for cough, dry cough, and A for angioedema. So ACE inhibitors, they can result in dry cough and angioedema. This side effect is not caused by angiotensin receptor blockers. These are the main clinical difference between ACE inhibitors and ARBs. Then P for prodrugs. Prodrugs. Prodrugs means ACE inhibitors are themselves inactive. They are metabolized to produce some compound which will result in inhibition of ACE. Except the first two drugs, all other prils are inactive. That means enalapril is inactive. It is metabolized to form enalaprylate. So enalaprylate will inhibit ACE. Similarly, ramipril is inactive. It is metabolized to form ramiprylate that will inhibit ACE. Perindopril is inactive. It is metabolized to perindoprylate that will inhibit ACE. So that means all the prils are prodrugs, but prylates are active. Except the first two, so captopril and lisinopril are not prodrugs. All ACE inhibitors are prodrugs, but captopril and lisinopril are themselves active. So all ACE inhibitors are prodrugs except captopril and lisinopril, which are themselves active. And this also you can remember. So we commonly study in anatomy anterior cruciate ligament. We commonly say ACL. So from the ACL or anterior cruciate ligament, you can remember that active ACE inhibitors are captopril and lisinopril. Active ACE inhibitors are captopril and lisinopril. All other ACE inhibitors are prodrugs. So prodrugs, all ACE inhibitors except captopril and lisinopril. Then T for taste alteration. ACE inhibitors can cause disturbance of taste, and the technical term for that is dysgeusia. So ACE inhibitors can result in dysgeusia or alteration of taste. Then O is orthostatic hypotension. Orthostatic hypotension, also called postural hypotension. So ACE inhibitors can cause postural hypotension, which is highest with captopril. among AC inhibitors, highest risk of postural hypertension is noted with captopril. And the risk of this side effect increases if a person has volume depleted state. Volume depleted state means if a person is taking some other drug which can lead to less volume, fluid overload, that can lead to orthostatic hypotension. So if we combine AC inhibitors with diuretics, the risk of postural hypertension increases. The next three are the contraindications of AC inhibitors. P for pregnancy. AC inhibitors are contraindicated in pregnancy. R is renal artery stenosis. Renal artery stenosis, particularly when it is bilateral. So bilateral renal artery stenosis, AC inhibitors are contraindicated. And I for increased potassium. Increased potassium means hyperkalemia. So AC inhibitors are contraindicated in pregnancy, bilateral renal artery stenosis, and patients with hyperkalemia. Then L, it says AC inhibitors lower the risk of diabetic complications like diabetic nephropathy. So in simple language, AC inhibitors are good drugs for diabetic patients. They lower the risk of diabetic nephropathy. So AC inhibitors, they are remembered as captopril. Now, angiotensin receptor blockers we discussed. Clinically, they are similar drugs as compared to AC inhibitors. The only clinical difference is they do not cause cough and angioedema. So you can remember that apart from CAP, rest all points also apply to angiotensin receptor blockers. That means angiotensin receptor blockers can also cause dysgeusia. They can also cause orthostatic hypotension. They are also contraindicated in same three situations, mean pregnancy, bilateral renal artery stenosis, and hyperkalemia. And they are also very good drug for diabetic patients. So the only thing which we need to know now is the names of angiotensin receptor blockers. Angiotensin receptor blockers or AT1 receptor blockers. The name of these drugs end with sartan. Any drug whose name end with sartan is angiotensin receptor blocker. The examples are losartan, valsartan, telmisartan, irbesartan, iprosartan, candesartan, and some more also are present. So any drug whose name end with the sartan is angiotensin receptor blocker. And actually you can remember the sartan stand for S means selective, A means AT1, RT means receptor, and AN means antagonist. So sartans are selective AT1 receptor antagonists. Selective AT1 receptor antagonists. Now among the sartans, one special point to remember is telmisartan. Apart from inhibiting the angiotensin receptors, telmisartan also stimulate an enzyme called as PPAR gamma. Peroxisome proliferator activated receptor gamma is also stimulated by telmisartan. And the drugs which stimulate PPAR gamma we will discuss in diabetes. Glitazones are the drugs like rosiglitazone, pioglitazone like drugs. So telmisartan also have similar action and it is also used to reverse insulin resistance. So telmisartan has additional action to reverse insulin resistance because it stimulates a receptor called PPAR gamma.
So tell me the name of an ARB which can decrease insulin resistance. I am not asking, I am telling you, tell me. Tell me means telmisartan. So telmisartan is a ARB which has PPAR gamma agonistic activity and it decreases insulin resistance. Clear? Now another important drug in this category which is losartan. Losartan can cause decrease in uric acid. Remember, most of the drugs used in hypertension like beta blockers or thiazides, they have problem of causing hyperuricemia. So they are avoided in gout. But losartan can cause lowering of uric acid, decreases uric acid. From the name you can remember it says LO means lower uric acid. So losartan will decrease the serum uric acid.
So these are the important points regarding the angiotensin receptor blockers also. So that means we have completed drugs for chronic CHF. The aim of treatment in chronic CHF was number 1 to decrease work, which we do by vasodilators. Number 2 to remove fluid, which we give by diuretics. And number 3 to reverse left ventricular hypertrophy, which can be done by beta blockers, AC inhibitors, angiotensin receptor blockers, or aldosterone antagonists. So now we'll move to some new drugs in congestive heart failure. And among the new drugs, the most important thing that we will discuss is the new strategy. And that strategy is to target a compound called as BNP. BNP is brain natriuretic peptide. So as the name tells, it causes natriuresis. Natriuresis means loss of sodium in the urine. Natriuresis. Apart from natriuresis, all the natriuretic peptides, they are powerful vasodilators. So the function of BNP is it causes natriuresis and vasodilation. After production, brain natriuretic peptide is metabolized. And the enzyme which metabolizes this is called neutral endopeptidase. Neutral endopeptidase. The other name of this enzyme is neprilysin. Neprilysin or neutral endopeptidase. It breaks brain natriuretic peptide. Now what do you want to do to BNP in patients with congestive heart failure? Will you like to increase BNP or you like to decrease BNP? Obviously we will like to increase BNP because we want to remove sodium, we want vasodilation. So if we increase BNP, we can treat CHF. And how to increase BNP is, one option is to give BNP from outside. If we give BNP from outside, it will produce same function. Second thing we can do is, we can inhibit the metabolism of BNP. If BNP is not broken, its level will increase. So same function will be produced. So we have two type of drugs. One which is BNP given from outside, and second which is neprilysin inhibitor or NEP inhibitor. So starting with first drug, BNP given from outside. The name of the drug is naziritide. Naziritide. Naziritide is nothing but recombinant brain natriuretic peptide. Recombinant brain natriuretic peptide. The main problem with this drug naziritide is, the name says it is a peptide. And what is the problem of being a peptide? Any peptide cannot be given orally. The reason? There are lot of peptidases present in the GIT. We have pepsin, trypsin, chymotrypsin and many more enzymes present in the GIT. So they can break peptides. So no peptide is effective orally. So is BNP. So naziritide need to be given by intravenous route. Not effective orally. So it has to be given IV. Second problem with the naziritide is it is BNP. Because it is BNP, so it can be metabolized by neprilysin or neutral endopeptidase. So because it is broken by endogenous enzyme, it is very quickly metabolized. So it is short acting. So naziritide is given IV and it is short acting. So it is indicated only in acute cases. It cannot be used for long term, only used for acute cases. So the first drug is naziritide. Second thing, we can inhibit NEP or neprilysin. So if we inhibit neprilysin, the BNP cannot be metabolized. So BNP level will increase. So that will treat the congestive heart failure. And the drug which are neprilysin inhibitors, NEP inhibitors, their name end with trill. Just like we discussed, the drug inhibiting ACE end with prill. Similarly, trills inhibit NEP. The example is sacubitril, and icadotril. Sacubitril and icadotril. Remember, prill inhibit ACE and trill inhibit NEP. Now, these drugs are effective orally. Naziritide was injectable, but trills can be given orally. Then we developed one more group of drugs which are called vasopeptidase inhibitors. Vasopeptidase inhibitors are those drugs which can inhibit two enzymes. They can inhibit ACE as well as NEP. That means vasopeptidase inhibitors have properties of both prills as well as trills. So the drug having both the property, that means property of prill as well as trill, that means AC inhibitor plus neprilysin inhibitors, they are called vasopeptidase inhibitors. And the drug in this group is, we have drugs like omapatrilet and sampatrilet. Omapatrilet and sampatrilet, they are vasopeptidase inhibitors, that means AC inhibitors plus NEP inhibitors. And again, from the name you can remember these drugs. You can find that in the name they contain trill. So when trill is present in the name means they are NEP inhibitors. Now if we see the name again carefully, we will find that the name contains at two places. At is present here and at is present here also. So these two ats will cancel each other. So if we cancel at with at, this at cancels this at. So what is the remaining is prill. So you can find in the name it is containing prill also. In the name it is containing trill also. So prill means AC inhibitor and trill means NEP inhibitor. So these have both the properties. Now because they are AC inhibitors, so they will have same two side effects. That means they can cause cough and angioedema. Cough and angioedema are the side effects of vasopeptidase inhibitors also.
Another new drug in CHF are called as ERNI. The full form of ERNI is angiotensin receptor blocker plus neprilysin inhibitor. So just like we discussed that in case of omapatrilet like drugs, the drug has combination of two things. That means they are inhibiting neprilysin as well as they are inhibiting ACE. But because of AC inhibition, they can cause cough and angioedema. So if a person develops cough and angioedema, then we cannot use AC inhibitors. So if we want to use similar combination, we wanted that the drug should have combination of angiotensin receptor blocking property so that cough and angioedema do not occur, and along with that neprilysin inhibition property. But we were not able to create such a drug, a single drug which has both of these properties. So what we do is we give two separate drugs to produce this effect. Means one of the drug is angiotensin receptor blocker and second drug is NEP or neprilysin inhibitor. And what is the combination is angiotensin receptor blocker we use is valsartan and neprilysin inhibitor we use is sacubitril. So this combination of valsartan and sacubitril is known as ERNI, angiotensin receptor blocker plus neprilysin inhibitor. So this is important drugs which are targeting the BNP pathway. That means increasing the brain natriuretic peptide by inhibiting the metabolism through NEP inhibition. Clear? Now apart from the BNP pathway, the another method of treating the congestive heart failure is a drug called as ivabradine. Ivabradine. This is a drug, as the name tells, which act by causing bradycardia. We know when we decrease the heart rate, then the work of heart decreases. In CHF, the work is more. So we can use this drug to produce bradycardia, and it acts by blocking a current known as funny current. The symbol of current is I. There is a funny current in the heart. In SA node, it acts by blocking the sodium channel in SA node, which carries the funny current. More detailed mechanism you will see later on in treatment of angina. This drug is also used in angina. The major side effect of ivabradine is VA means visual acuity. It causes decrease in visual acuity. So from the name itself, you can remember everything. Ivabradine, I means IF blocker, means funny current blocker. VA means visual acuity is reduced, it is side effect. And brady means it is bradycardiac agent, it decreases the heart rate. So principal mechanism in CHF is causing the decrease in work of heart by decreasing the heart rate. Okay. Then the last group of new drugs, they are vasopressin antagonists. Now, before going into details, we should know the basic things. What is the other name of vasopressin? Yes, the other name is ADH. So vasopressin, the other name is antidiuretic hormone. Now, why I am talking about two names? Because it has two major functions which are written in the name itself. So vasopressin says it causes vasoconstriction and antidiuretic says it decreases urine. But these actions are mediated by different receptors. So when vasopressin, it stimulates V1 receptors which are present in the blood vessels, it results in vasoconstriction. When vasopressin acts on V2 receptors which are present in the kidney, it decreases urine. So vasopressin has two actions, one vasoconstriction, second decrease in urine. So which action you want in CHF? None of them. We do not want vasoconstriction, rather we want vasodilation. We want to decrease the work. And second, already there is edema, so we will not want to decrease urine. We will want to increase urine. So what we will do? We will block these receptors. So if a drug block these receptors, by blocking V1 it will cause vasodilation, and by blocking V2 it will increase urine. So that drug can be used in CHF, and these drugs are called as vaptans. The drugs which block the vasopressin receptors are called vaptans. Two important drugs in this group are conivaptan and tolvaptan. Conivaptan and tolvaptan. From the name itself you can remember, it is saying VA means vaso, P means pressin, vasopressin, and if we put the T here, it will become ANT, means antagonist. So vaptans are vasopressin antagonists. Vaptans are vasopressin antagonist. The major difference between the two vaptans is conivaptan is given IV, whereas tolvaptan is given orally. Tolvaptan is given orally, conivaptan is given intravenously. Now this tolvaptan, recently it has also been approved in autosomal dominant adult polycystic kidney disease. Tolvaptan is recently approved for autosomal dominant adult polycystic kidney disease. So these are the important new drugs which are used in congestive heart failure. Okay.